Let me call Dr. Narayanan, the senior most and pioneer in refractive surgery in Kerala, to talk on. Sir will be talking on ideal candidate for refractive surgery.
Good morning, everybody. Shall I start?
Yes.
The topic given to me is ideal candidate. I feel that we should have some judicious flexibility, and there is nothing called ideal now. So, judiciously, you have to employ the flexibility. The basic patient selection criteria, the age below 20, preferably above 21 years. But in certain cases of job requirement, marriage, etc., you can do after the 18. But below 21, the chance of regression is more. That's why ideally it is above 21. Then stable refraction for 1 year, refusal to continue glasses. You're using contact lenses, soft lenses you have to withdraw 2 weeks before, and rigid lenses 4 weeks before. Contact lens intolerance, absence of corneal pathology, realistic experience from the procedure, properly obtained informed consent. Absolute contraindication of corneal abnormalities, external eye diseases, significant cataract, pregnancy, lactation, uncontrolled diabetes, glaucoma, uncontrolled systemic autoimmune syndromes. The possible contraindication, abnormal wound healing like keloid, history of herpetic keratitis, controlled diabetes, glaucoma, and autoimmune disease. Investigation, accurate refraction using retinoscopy, slit lamp biomicroscopy, pachymetry. Ideally, should be above 500 or 490 microns. For me, it is above 490 microns. Sherman's test, tear production above 10 mm, tear film breakup time about 30 seconds, the normal intraocular tension by pulsar tonometer, binocular indirect ophthalmoscopy, rule out retinal conditions, topography and pentacam scan to exclude anterior or posterior ectasia. You have to very carefully study in the pentacam anterior sagittal map, anterior and posterior elevation maps, and cornea thickness map. Don't reject patients simply because they don't, without doing the retinoscopy. In the recent changes in the glass power also, you should not discard the patient. Before you doing retinoscopy and show that actual power is less than the power of the glass they are wearing. Because the accommodative element is not taken into account, and hence the retinoscopy value, if they accept, that should be taken into account. Don't reject a patient with dry eyes until you trial lubricant eye drops with Hylice and cyclosporin eye drops, and till you exclude the history of oral medicines like antihistamine, diuretics, systemic conditions like thyroid disease. You have to see the tear breakup time, tear meniscus, and blinking rate in addition to the Sherman's value. Don't reject a patient with low PACI value also until you assess the visual acuity, quality, and the patient actually which quality and what is the patient need. Patient with higher powers may be already adapted to less resolution, less contrast sensitivity, and poor binocular vision. Also, the pupil diameter, residual bed after ablation are to be considered. The age of the patient and his profession. You can modify the optical zone, can undercorrect. Marginal adjustment you can do even in the residual field. Can accept certain keratoconus cases. This I want to stress. Certain selected cases we can even do it, although it's a contraindication. The patient has low power, patient should be willing for C3R procedure later or as a combined one. Patient has come for the refractive surgery to fulfill his job requirement or for some other genuine requirements like marriage. In certain cases, the combined procedure has even reversed the keratoconus. Criteria selection above 490, Sherman's test I already mentioned, pentacam and this refractive status, the sphere should be below 10D and cylinder below 5D. In one case where a keratoconus case, they got a low power only, 1.75 with a 1.75 cylinder. And the pentacam shows that posterior ectasia in this case, or the early case of keratoconus. And the surgery was done in 2018 in this case. The combined procedure, PRK with the C3R. And the post-operative, the vision was 6/6 partial, both eyes. And after 1 year, the pentacam shows it's completely reversed. Like you can see that. And even now, the patient continues the same vision, and the pentacam readings are normal. Thank you so much.
Thank you, sir. It was very really informative. So one thing, do you? No, sir. Please come. This is. Sir, in glaucoma, you said if once you control, will you take the patient for refractive surgery or established case of glaucoma?
Glaucoma still, if it is controlled, I'll take for PRK, not for LASIK.